Now we are passing through a very emergency condition of the country and in the internet and globally with the COVID pandemic. And what I personally believe, the show must go on even in emergency, and in this particular time what I have decided to take some classes on this YouTube. So these are not very well prepared classes, but what one must know that I will try to cover in this lecture. Now today's topic is the pharmacological basis of therapeutics in heart failure. Now what is heart failure? The heart failure is a condition defined as in where heart cannot pump the blood properly to meet its metabolic demand in spite of adequate venous return. So this last point I have collected from some old books because that's the only point which will discriminate heart failure from that of a shock. In the shock, what happens, the venous return is not adequate because there is a volume depletion, but in heart failure what happens, there is a volume depletion is not there. And one point which is important, just by noting the jugular venous pulse, you can set up your strategy where the patient is suffering from the shock or from the heart failure. Otherwise, in both the conditions, the heart is not pumping adequately to meet the metabolic demand. In the shock, you have to give the fluid, but in heart failure, it is totally contraindicated. Now, keeping this in mind, there are certain terminologies one must know. What is right-sided failure, what is left-sided failure, what is high output failure, what is low output failure. So as I said, the cardiac output is not adequate. That means your metabolic need is all right, but that metabolic need is not adequately being supplied by the cardiac output. That is called as the low output failure. And at times the cardiac output is adequate, it's normal, but your metabolic demand is high, we call it a high output failure. As for example, in anemia, in fever, in thyrotoxicosis, your metabolic demand is high, but your cardiac output is normal, and that normal output is not sufficient to cope up with your metabolic demand. So that is a high output failure and low output failure. The treatment of the high output failure is the treatment of the basic cause. Suppose the thyrotoxicosis, you treat the thyrotoxicosis. If it's anemia, you treat anemia. If it's a beriberi, treat beriberi, and your this heart failure condition will be taken care of. Now, what happens? We look into the circulation of the heart. What happens? Normally, there is the superior vena cava, there is the inferior vena cava, and all these two drains in right atrium. This is your right atrium, and from the right atrium, this blood goes to the right ventricle. From the right ventricle, blood goes to the lungs. Where the blood is oxygenated. From the lungs, the oxygenated blood goes to the left atrium. And from the left atrium, it goes to the left ventricle, and from the right ventricle, it is pumped out into the circulation. So the right-sided failure, what happens? There's a stagnation here. That means right ventricle and left atrium, there's a congestion, and it is manifested by rise in the JVP and peripheral edema. Whereas the left-sided heart failure is manifested as a dyspnea, and pulmonary congestions. conditions. This is how the right and the left heart failure they differ. And since if you take a section of the heart, the both ventricle, it is like a figure of 8. So the left ventricle or the right ventricular failure, ultimately they merge together, you cannot differentiate. So all the features of the heart failure, it comes into play. Now what happens, there are certain terminologies we very frequently say, is the preload, afterload. Afterload means what the impedance is getting to push the blood out of the left ventricle, and the preload is the amount of the blood what remains in the right ventricle or in the left ventricle at the end of a pumping. Now, why heart fails? There are so many reasons for the failure of the heart. It may be due to the defect in the heart actin myosin coupling. It may be due to the valvular lesions, or it may be due to some other causes like anemia, thyrotoxic. Thyrotoxic is what I have said, but here the basic treatment. হ্যাঁ বলুন হ্যাঁ পুরোটাই দিন, একটু পরে ফোন করে আমি একটা ক্লাস নিচ্ছি, ঠিক আছে? আচ্ছা আচ্ছা ঠিক আছে। What are you talking about?
So, different afterload and preload.
Afterload and preload. So this has to be taken care of, and the heart muscle itself has to be taken care of in order to treat the heart failure. Now, the different drugs which are affecting the heart failure can be categorized as classified as there are some drugs which acts on the which increase the contractility of the heart, what you call the inotropic drugs, and there are other drugs which are not classically the inotropic, but they take care of the preload and the afterload and the cardiac muscle indirectly. Those are other non-inotropic drugs. Now, among the inotropic drugs which top the list is the digoxin. Digoxin is called cardiac glycoside. That means, what is glycoside? When a sugar molecule sugar with the help of an ether bond, we call it the glucoside. When sugar combines with non-sugar, we call it the glycoside. When sugar combines with the amino sugar, it is called aminoglycoside, which is a very big list of drugs or aminoglycosides are there, like streptomycin, gentamicin, kanamycin. So digoxin is the cardiac glycoside because here the sugar is combined with the non-sugar, and the non-sugar is your cyclopentanophenoxine ring. This is your just like a cholesterol ring. And here the sugar moiety binds. The function of the sugar moiety, it is not going directly affects your heart, but it helps in the solubilization of the drug, and it alters your pharmacokinetics of this cardioglycoside. Now the cardioglycoside, what it does, in order to understand the mechanism of action of the cardioglycoside, one must know what is the basic mechanism of contraction and relaxation of the cardiac muscle. The basic unit of the cardiac muscle is a myocyte which contains actin myosin, and this coupling occurs, and for this the calcium is required. Say this is your heart muscle, And inside, in order to contract, this actin, myosin, calcium has to be there in the in this cytoplasm. Now, normally what happens, the sodium is outside of the cell and potassium is inside the cell, because there is a pump operating what we call the sodium potassium ATPase pump. Sodium potassium ATPase pump. Apart from this, there is another pump which is called sodium calcium exchanger. Sodium calcium exchanger. And there is another leg channel, what is your L type of calcium channel, L type of calcium channel. So what the digitalis does, it inhibits the sodium potassium ATPase pump, it inhibits it. And as a consequence of this inhibition, what happens is, instead of sodium is outside, it remains inside and potassium goes outside. So intracellular concentration sodium goes up. This intracellular sodium will invite more calcium to be inside, and from the cytoplasmic reticulum also the calcium is released, and there is a more release of the calcium inside the cytoplasm, which will help in the contraction of the actin myosin complex. Am I clear, or should I repeat? So what happens? The site of action of the sodium, this cardiac glycoside, is the sodium potassium ATH pump. The sodium potassium ATH pump is responsible for the exclusion of the sodium from the cell outside, and it keeps the potassium inside. When this pump is inhibited, sodium, instead of being outside, comes inside. There is another pump which is called sodium calcium exchanger. What it does, it throws the calcium outside and throws the sodium inside. So when the intracellular concentration of sodium increases, it, instead of throwing the calcium outside, it throws the calcium inside. Therefore, the concentration of the calcium inside the cytoplasm of the cardiac cells increases, and therefore there will be better contraction of actin myosin complex, and heart will contract adequately. Now, apart from its action on the cardiac muscle, it has got other function too. What it does, suppose there is this sinoatrial node, there is a heart, there is the sinoatrial node. It decreases the action refractory period, it decreases the refractory period of SA node. And it increases the refractive period of AV node. So what happens if there is an atrial fibrillation, if the heart contracts, if the atrium contracts rapidly, what we call the atrial fibrillation, and if the effective refractive period is decreased, what will happen? All the flutter will be converted to fibrillation, and there will be rapid bombardment of this fibrillation to the AV node, but here it is getting an obstacle because refractive period of the AV node has increased. So whatever bombardment from the SA node is coming, it is getting an obstruction, and it is ultimately decreasing your this defect of atrial flutter, which will be ultimately abolished. So what are the indications of the cardiac glycoside? It is effective in heart failure. Number two, particularly if it is due to heart failure due to atrial fibrillation. In our time, the other uses of heart failure, there's a 3 or 4 indications of the heart failure, but gradually this is the main indication of the cardiac digitalis nowadays, because it has been found, apart from this, it has many other hazardous effect on the cardiovascular system. Now, it may stimulate this chemoreceptor trigger gene to produce nausea and vomiting. It may, if you take the ECG tracing, it can produce any variety of the cardiac arrhythmias, whatever you know. It may be produced by the digitalis, and since it is a steroid nucleus, and sex hormones are the same nucleus, therefore gynecomastia is one of the commonest side effects of this cardiac digitalis. Now, if a patient of digitalis toxicity comes, what to do? You have to give the potassium, because potassium is a drug. What it causes? It inhibits this attraction of the cardiac glycoside to bind with the sodium potassium ATPase pump. That means it makes the sodium potassium ATPase pump free, so that its toxicity is decreased. What else you can give? You can give the phenytoin or the lignocaine if there is a ventricular arrhythmias arising out of this digitalis toxicity. So apart from this, what are the other inotropic agents? Those are the bipyridones. Bipyridines, amlodipine, milidone, these are the bipyridines, has to be given intravenously, and they are all inotropic agents, and they are generally given in emergency setup in intensive care unit. Dopamine, dobutamine, these are all inotropic agents, may be given in order to keep the heart pumping. Other drugs, which is a glucagon is also given for this heart failure, because an inotropic agent, and it is given if there is a beta antagonist poisoning also. I will tell you how. So there is a cardiac muscle, there is the dopamine receptors, there is the beta receptors, it is the glucagon receptors. What they do? They stimulate cyclic AMP formation, and this cyclic AMP ultimately forms cyclic AMP in active form, and here the enzyme involved is the phosphodiesterase inhibitor. That is 3 isomer. There are many varieties of the phosphodiesterase. Phosphodiesterase 3 is responsible for the inactivation of the cyclic AMP, which is responsible for the inotropic effect of the heart. And what this group of drugs does, they block this phosphodiesterase 3, and therefore the cyclic AMP level increases, and therefore it is an inotropic agent. Am I clear? Now the third group of drug is the glucagon. Glucagon also stimulates the cyclic AMP, and this is your glucagon is a hormone liberated by the pancreas alpha cells, which is a hyperglycemic hormone, but which is also your inotropic agent. Now apart from this inotropic agent, a big list of drugs can be used for this heart failure, and those drugs are diuretics, but two group of diuretics are never used for the heart failure. One is osmotic diuretic, and second is carbonic anhydrase inhibitors. They are never used for the heart failure condition, because if you give the osmotic diuretic, there is a further volume overload, and your condition of the heart failure will deteriorate. So the two diuretics never used. And what diuretic is used? The diuretic used is thiazide, potassium sparing, and and loop diuretics. They are used for the heart failure. And you just give your name like furosemide, then spironolactone, amiloride, or eplerenone, they can be given in heart failure condition. Now, other drugs what can be given for the heart failure are the beta antagonist. Beta antagonist in our time, beta antagonist among the beta antagonists, celiprolol, metoprolol, there is a common carbidiolol, they are commonly used, and the basic mechanism what it does is it decreases the heart rate, and the heart rate is decreased, that means the oxygen demand for the heart rate is decreased, and your purpose is served. Ivabradine, একটু পরে করবেন, একটা ক্লাস নিচ্ছি, ঠিক আছে? আচ্ছা আচ্ছা, একটু 10 মিনিট পরে করছি। So the ivabradine is the bradycardiac drug used for the heart failure. Now, ACE inhibitor, angiotensin converting enzyme inhibitors, a big list of drugs are there, and the ARB, angiotensin receptor blocker, they are also used for the heart failure, and a big list of drugs are there. Some are, I'm not mentioning the different names, I have not mentioned the different names of the ARB also, you can learn from your book, and how they are effective you can know. Angiotensin receptors there are two varieties, angiotensin 1 and angiotensin 2, and angiotensin 2 is also response to the cardiac remodeling. So if you give it for a long time, your heart, the damage of the heart muscle due to heart failure can be altered. Therefore, it is said to have some preventive role, or it can increase your lifespan of the heart failure, is said. Now, in order to decrease the afterload, if you remember that figure where I said of the left ventricle the blood is being pumped out, and if it is getting the impedance, so in order to prevent the afterload, the drugs used are the vasodilator. The vasodilators are of the three varieties. Some are arterial vasodilator, they generally decrease the afterload, and the venous vasodilator, they generally decrease the preload. Therefore, if you can reduce the if you can cause the venous dilatation or the arterial dilatation, your heart failure condition will go towards the betterment. So these two group of drugs, and some are combined arteriovasodilator. The bipartisan, what I have mentioned, they are also called ionodilator because there is the inotropic effect, plus it has got the vasodilatation effect also. Now, if you remember, from the atrium, some peptides are released when there is a failure condition of the heart, and those peptides we call the atrial ANP, atrial natriuretic peptide. In the same type, B-nitrotic, we call the B-nitrotic peptide, brain natriuretic peptide, and the C-nitrotic peptides. And this drug takes it makes some compensatory adjustment in patients with the heart failure. And their main function is the natriuresis, that means they release the sodium, and they have got some vasodilatation or atrial dilatation property also. So if you have a drug which has got BNP like property, it will be effective in the heart failure, and the drugs are nesteride. What's the spelling? NESTRID. Nesteride is a drug which is an analog of the BNP, and this BNP is metabolized by aminopeptidase, and the drug is omnipratet, and somnipratet, etc. So these are some mechanisms how the drugs are effective. Now one hormone is released from the posterior pituitary, and that hormone is vasopressin, and this vasopressin acts on the different vasopressin receptors, and the main function of the vasopressin is to draw the water and the sodium. So it is a deleterious effect for the heart failure. So if you have a hypernatremic condition, on that time, convaptan, tolivaptan, this is a drug which can be used because they inhibit the sodium retention property of the vasopressin. So this is in brief the different drugs which are effective in heart failure.